The subject of specialization of pediatric surgery, challenges and opportunities. So, based on this, we try to do a study to see the subspecialization status in Nigeria among pediatric surgeons. But from backgrounds, globally, there's a shift from practicing as a general pediatric surgeon to subspecialization within pediatric surgery. It is subspecialization in surgery has been identified as one of the ways of ensuring delivery of excellent service and encouraging innovative breakthrough in a particular area of surgery. Countries in Europe and America are delving into micro specialization in a particular subspecialties in pediatric surgery due to its social benefits. Current practice, patterns, and opinions regarding subspecialization within pediatric surgery are not well known among Nigerian pediatric surgeons. So we aim to establish the current subspecialization status of specialist pediatric surgeons in Nigeria and their attitudes towards subspecialization. So we obtained an institutional review board approval. After that, an anonymized survey was sent to all consultant who are members of the Association of Pediatric Surgeons of Nigeria. The survey was initially sent on September 24, 2023. A reminder was sent on 25th, and the survey was closed at the end of the month. The survey was created using the Google form. So, demographic variables including age, sex were obtained based on regarding place of practice, duration of practice, institution of practice, subspecialty training and care were obtained. And space was created for an additional open-ended conversation regarding subspecialization among pediatric surgeons. So the results, what's the total number of practicing pediatric surgeons in Nigeria is 1.5, and we received a total of 56 responses, giving a response rate of 45%. We had a new ratio is 1 and rate rate from 35 to 65 years. So the place of practice, we realized that majority of the respondents we are practicing in teaching hospitals, and only a few we are practicing in private hospitals, as you can see from the slide. Now, we also looked at the status of the place of practice. We see that only 45% had full accreditation. That's quite a large number. While 23% had partial accreditation, and 32% had full accreditation for training pediatric surgeons. This is important because if there is no accreditation status for training pediatric surgeons, then we cannot actually be accredited for subspecialty training. Now, we looked at the duration of practice as a pediatric surgeon. Majority of the respondents were below 11 to 15 years of practice, as you can see in the slide. Then, distribution of practice. It's important to realize that most of the respondents were general pediatric surgeons with interest in specific area, as you can see, 57.1% of them, while only 3.6% were true specialists. These are people that have actually subspecialized after their training as a pediatric surgeon. Now, look at the cadre of the respondents. Most of the respondents were senior lecturers, and only few were veterans. Then I wanted to find out if our opinion about subspecialization. Majority of the respondents, 52 of them actually agreed that subspecialization will improve practice. But also it was interesting to know that there is still a small fraction, about 6, that believe that subspecialization will not improve practice. Now we looked at the policy to limit surgery in a particular surgery. Limit surgery to a particular surgery in an institution. This we believe will actually encourage subspecialization. But we realize that majority of the centers does not do that. Most pediatric surgeons do not do that, still do everything. There is no policy to limit a particular surgery to a particular surgery. Probably maybe a multiple surgery, rheumatologic causes should have been limited to a particular place, and why maybe trauma will be limited to a particular place. It's only done in 60% of centers. Now, we also looked at the subspecialty of interest. Most of the respondents are interested in neonatal surgery, oncology, and so if we want to develop a subspecialty training pediatric surgeons, it will be nice to focus on these areas where most people have shown interest, like neonatal surgery or neurology and pediatrics. Now, we also looked at the likely duration of subspecialty training. A majority of them agree that 1 year is adequate for training. Then we looked at other comments because it is a mixed methods outcome used. So these were the interesting comments among all the comments that we have sent. After subspecialization, there may be unavailability of facilities to practice. Then centers should encourage to own specialization in certain areas. It is also important, it's practical, but whether subspecialization should be a priority presently is debatable. In conclusion, currently most of the pediatric surgeons are not subspecialists, even though they believe subspecialization will improve patients' outcome. Majority of them are interested in subspecialization, and 1 year subspecialty training appears to be adequate duration to acquire proficiency in a particular subspecialty area. Thank you.
Thank you very much for that presentation. Now we're going to listen to management of post-circumcision total penile loss from electrocautery injury. It's a case report and a review of the literature. Ogundele will present on behalf of the authors. I believe it's from Shadam. Yeah. Once the time once your talk comes up, we'll not give you time to look for how you will do slideshow. So make sure you're ready. You can correct the mic.
Good morning, the moderators, ladies and gentlemen. Ogundele, I'll be presenting on behalf of myself and the other co-authors. Management of post-circumcision total penile loss from electrocautery injury, case reports and review of literatures. Like we all know, circumcision is a common surgical procedure done globally, especially in sub-Saharan Africa. Complications associated with this procedure are also equally common, range from bleeding to infection, injury to the glands, as well as total penile loss, as we'll be presenting this morning. It is a rare but fatal circumcision mishap, often caused by electrocautery injury. Total penile loss poses serious physical and psychological challenges to the patient, his parents, as well as the managing team. Successful management of this condition requires skillful use of counseling psychology to ameliorate the mental body, as well as appropriate surgical skill sets and facility to reconstruct a functional and cosmetically acceptable phallus. We managed a 4-day-old neonate who had freehand circumcision carried out by a medical officer using monopolar diatemy for hemostasis. After the procedure, the patient came back for a change of dressing about the second, third day, and there was progressive dusky penile discoloration and excessive crying necessitating referral to our facility on the 9th day. Yeah, the slide is showing the necrotic and gangrenous phallus down to the base. Examination revealed an irritable baby with penile gangrene who was resuscitated and stage management carried out by a multidisciplinary team. The mother developed morbid features of psychological stress, which led to some suicidal ideation, and this was managed in collaboration with clinical psychologists and medical social workers. At other points, the father demonstrated aggressive tendencies towards the referring doctor and our managing team. Both parents were given further counseling and they had improved mental status subsequently. Penile reconstruction was subsequently carried out by corporal stump exploration and mobilization with full thickness left groin skin cover, done 6 months post-injury. This is a set of pictures showing the sequence from the initial presentation to catheterization. We were able to successfully catheterize the urethra, and then after serial debridement, the wound became cleaner. And at 6 months, we did the exploration, and the lower middle, because I was not showing it, the lower middle is showing the immediate post-op surgery, and then the 18 months after surgery. Subsequent recalcitrant meatal stenosis developed that was not amenable to dilatation, so we did a suprapubic cystostomy, which was discontinued after we did a generous meatoplasty. There was acceptable cosmesis, good urinary stream, and straight penile length of 4 centimeters during the latest follow-up at 2.5 years. Researchers have documented that the use of electrocautery in should not be encouraged because of the complications. Monopolar diatomy is responsible for most of these total penile loss. Cases are classified, this case is classified as a grade 4 penile injury and have been reported to involve the use of electrocautery. Other causes of total penile loss include severe trauma, penectomy for cancer, iatrogenic causes from hypospadias repair, grafting surgery, and repair of bladder extrophy. Salvage surgeries have been done with satisfactory outcome. The release of the subcutaneous corporal remnant is projected as the best reconstructive technique for this injury. Muscle flaps have also been used. Other experts have considered the option of gender reassignment, which has been done in some patients, but the outcome is very poor. Multidisciplinary is essential in the management of total penile loss. Suprapubic cystostomy may be employed at the primary of presentation during reconstruction or post-reconstruction as done in our patients. Penile length, erection, urinary function, and fertility are some of the concerns for long-term outcome. Sorry, I'm trying to see if I'll be able to show this video. This is showing the outcome for the patient at the latest follow-up. It's not showing. It's showing on my laptop, but not showing on my. So I wanted to show the urinary flow, the patient boiling and okay, so this is showing what we've been able to achieve at the latest follow-up. The child is able to void with spiraling of the urinary stream. The mother and caregiver reported good penile erection, and good psychological well-being for both. So in conclusion, electrocautery for hemostasis during circumcision is a cause of total penile loss and should be discouraged. Total penile loss can be successfully managed by prompt resuscitation and corporal stump mobilization in a multidisciplinary team. These are some of my references, and thank you very much for listening.
Thank you very much for that presentation. As the presentation was going on, I was going to commend the audience for really keeping quiet so we could hear, but I think the noise is back. Let's just try and pay attention to these presentations. And I think the IT guys should get the screen working. We here cannot see what's going on. So can we please activate that while we get the next presenter?
Thank you very much, Chairman. The next presentation is by Dr. Shola, catastrophic expenditure associated with pediatric surgery in low resource setting, a prospective multi-center study, preliminary findings. Shola, okay, take the mic. The second mic should also come.
So, 2 days time cannot start unless it's ready. So just wait for it to be ready.
Good morning. Dr. Shade, I'm presenting on behalf of our colleagues. This is a presentation on catastrophic expenditure associated with pediatric surgery in low resource setting. These are pulmonary blocks. I'm presenting on behalf of our colleagues. So the background, catastrophic expenditure is healthcare expenditure that poses significant financial burden on households globally, particularly in our resource limited setting. It is an out-of-pocket expenditure of more than 10% of the patient's annual income or 40% of annual household expenditure after full expenditure of the government. About 150 million people experience catastrophic expenditure globally. About 100 million poorer as a result of this health expenditure. The determinants of this catastrophic expenditure span over the economic status of the family, inequality within the family, incidence of hospitalization, presence of a member that have morbid condition, particularly elderly or disabled individual or individual with chronic illness. These are the key factors. The aim of the study is to primarily to identify the prevalence of catastrophic expenditure due to pediatric surgical procedures in our setting. Also to explore funding alternatives for patients and to determine the prevalence of catastrophic expenditure based on different pediatric surgical procedures. This is a prospective, multi-center ongoing study that involved 26 hospitals within the country that practice pediatric surgical care. About our target is to get 1,500 patients enrolled, and the central hub for NIPHR Global Surgery Unit in Lagos hosts this procedure. We started by getting the national institutional approval and institutional approval before the study was commenced in these centers. Our target is children that are less than 15 years, and we capture all pediatric surgery cases besides day cases. Our primary outcome is to find that proportion of catastrophic expenditure and also to see alternative source of fund. All data were captured on record and funding were supported by the Nigerian hub in Lagos. A total of 20 centers were able to collect data for us after expert approval. As of the time we are submitting for this conference, we have 704 that have been uploaded. The composition of the centers includes teaching hospitals, general hospitals, and some private hospitals. These are the spectrum of hospitals that are involved. We have the highest from University of ILORIN here, Lokoja, ABU, followed by Luth. Most of our patients are actually male. More than 65% of our patients are male. The distribution, most of our patients are less than 2 years, but it spans over up to 14 years. The surgeries that are performed are predominantly elective surgeries, about 70% of that. And most of these cases are actually laboratory for peritonitis. For source of fund, we observe that out of pocket is the most important majority of these applications, about 53%. But it's important for you to also note that loan and sale of property also contributed, constituting about 75% of source of fund. Only about 15% have access to health insurance. And this reflects what we see nationally.
Also, the casualty expenditure was observed in about 7.5% of our patients. So this is greatly high. We compare gender. We notice that casualty expenditure are more common when the patient is a male child. We also noted that casualty expenditure is more in children that are younger. We try to compare the maternal level of education and incidence of casualty expenditure. We noted a significant high casualty expenditure in those individuals that have secondary education and those ones with higher education. A similar picture was seen. So, abdominal surgeries have been strong cause of surgeries that are done in the setting. The early study have shown unacceptable elevated high level of casualty expenditure of 57%. We noted that pediatric surgery expenditure, out of pocket, loan, and self property constitute about 75% of casualty expenditure. Then we noted that the educational status of the parents, the age of the patients, and the economic status of the family also affect the expenditure. So our conclusion is our progress is that we have a unacceptably high expenditure in our setting that is posing the stress of the family. We identify education and family structure as a factor that can affect this. The effect of age we that require further study to see how it really affects the expenditure. We advocate for support of families in care for pediatric surgical surgeries, and we encourage that children care should be included in national health insurance to assist this family. I want to note that the NIHR Hub Center in Lagos is supporting us for this study. Thank you very much for listening.
Thank you very much, Tunde. We'll go straight to the next presentation, Epidemiology of Childhood Injuries in ILORIN. And Professor Nassim will lead that presentation on behalf of the authors.
Good morning, Mr. Co-chair. I adopt the assistant protocol. I'm A.A. Nasir. I'll be presenting our work on the epidemiology of childhood injury in ILORIN, a prospective study. Injury has been reported as the leading cause of death for children over the age of 1 year. The highest body of this injury is seen in low and middle income countries, where 95% of this injury deaths occur. And WHO has estimated that about 100 children worldwide every hour. So meaning as at the time we are here, about 100 children will have died. And there's injury have severe physical, psychological, and socioeconomic consequences. Therefore, the aim of this study is to determine the epidemiology of pediatric injury present in our emergency room teaching hospital. This would be would be like a background for us to know the local policy to adopt in preventing this injury. It was a prospective study of pediatric trauma admission in our center from 2011 to date to July 2024, spanning about 13 years. Data was collected from patients who were admitted in an emergency room. Usually children less than 15 years. We have a total of 994 children admitted over this 13 years, middle age of 7 years. Both by majority 741. while about a third of them were under 5. If you look at the location where this injury occurred, it's very revealing. Most of this injury occurred at home, about 43.6%, followed by highway, meaning when they are crossing the road. And it occurred mostly during leisure time, 42.8%. The magnitude of injury, majority of this injury were road crash and occurred to children as pedestrians, 40.1%. And most of the close to that is children who sustained injury from fall, about 37.8%. We will see that about 60% of injury was from motorcycle collision, and about a fifth of them were pedestrian, while another 12% occurred to them as passenger on the motorcycle or car. The injury are mostly extremity fracture, followed by traumatic brain injury. We just look at the initial outcome of this injury, why they were in emergency within 2 weeks of admission, and you will see that majority of them were discharged. Majority were admitted to the ward, 764. 136 were admitted, 18 were admitted to ICU, and 5.3% of the children died during this period under review. We concluded that this finding suggests that mortality in our setting is still very high, and most of it is from road traffic crash. Most of this injury occur at home during leisure, so it suggests that our home is not safe for these children, and we need to pay attention to their safety, either from design or supervision. So we suggest that parental education will be important to reduce this burden of child injury. Thank you for the attention.
Thank you, Dr. Nasri, for your good presentation and on time. The last for this session is isolated diaphragmatic rupture following building collapse. Saad Bashir. Is he presenting online or has he submitted? Okay, all right. So thank you very much. I'll hand over to the chairman to lead the discussion.
Thank you very much, Professor Mohammed. Any questions, comments, queries from the audience? Can I see any hands up? You can see Professor Ahmed. You guys are your own. Any more questions, comments? While Professor Ahmed is leading the discussion, we can begin to think of ours. Thank you very much, sir. Can you have a mic? A mic to Professor Ahmed, please. The mic to Professor Ahmed.
Thank you very much, session chair. It's not a question, just some comments. Thank you, Dr. Aduma, for that talk on subspecialization. I think that's where we need to go as an association. But what I was looking out to see was some clear recommendation about how we should strategically begin to develop those subspecialties. I do know that very recently the Faculty of Surgery at WACS has created a pediatric neurology training program. And the SG is here, so maybe he has more information about that. But I know from the faculty that program will start very shortly. And I think that Apson, maybe during the AGM, we need to now clearly outline which specific areas we think, given our current situation, we think that we should foresee what should be the modalities. I know many times that I talk with colleagues, what comes up is if I decide to focus on one small area, I will lose my skills in the other area. But I think that we should not be afraid of losing skills. you really can, if you want to become an expert, you can't do everything. So I want to hear from Dr. Adema what should be the strategic direction that we should go. Thank you.
Thank you very much. I think Apson has made his recommendation through our representative, Dr. Lawal, the faculty of surgery, was headed by Dr. Ramir.
Thank you very much, Mr. President. While we are still getting our questions together, I would also ask a few questions and make some comments. Dr. Numa, I think Mr. Ahmed, his disciple, was going to give you a few more minutes to tell us what is your take-home message. He didn't have that time. So while responding to his students, can you please do that? The next thing I want you to address is what is your definition of training? What is your definition of training? We were happy on accreditation status. I think they can have some people who can do subspecialty training without accreditation. It depends on what goes on in those centers. So what do you define as training? Then to Ogunjeli, I think that's a very, really indeed catastrophic. And the part I like about your presentation is the holistic care. Because if you ask me, maybe down the line, all these surgeries will have made a difference. But that psychological support is very important. And this now speaks to, for us who train young doctors, maybe we should start adding that into the curriculum to know when to use what, especially all these dangerous gadgets. For what's the next topic was my question to you is that you were talking about some parts, study is a preliminary study, it's ongoing. Based on the comments you made and some observations, do you have the ability to modify the study, knowing that you have found some things that may be incorporated or given more information? Do you have that ability? Professor Nasser, I think I like your epidemiology, brings us back to trauma. But when you came to your conclusion, you were mentioning road traffic crashes being the commonest, and that most of them occur at home when they are leisure. I don't know how you marry that, crashes at home. Those are my questions. Mohammed, do you have any?
Thank you very much, Chairman. Most of the things, but my comment on the subspecialty training, I think it's more to do with the workload. Like, for example, in a center that has 3 people, and then each one chooses a topic, what happened to the rest? So, this, I think, around our number, and we should make a lot of effort to see how we can increase the number. You will find out that even in a particular team, there are people that each among us knows that Mr. A or Surgeon A is better in 1 or 2 areas and so on. So sometimes sharing the responsibilities and also taking care of the others that doesn't strictly fall within those subspecialties, then probably it might help because you can't abandon certain children ethically because of their condition didn't strictly fall within. But I feel it is good to start so that when you, even if it is with 3 major, neonatal surgery, pediatric surgical oncology, and pediatric urology, probably we should concentrate on this. That will take care of about almost 50% of our workload. And then from there, gradually we can now move, since everybody can at least handle most of the general surgery cases. Thank you very much. Then my question on the penile loss. Is it really total penile loss? Or is it total skin and partial shaft loss? Otherwise, how do we mobilize? Where do we get the erectile tissues that the patient can still get erection? Um, this is something that always happens. I
them have interest in a particular area so that people will be willing to go into subspecialization. That's one thing. Then another thing is I want to look at the accreditation structure. from we looked at where people are interested in going. We saw that neonatal surgery, most of them are actually interested in neonatal surgery, oncology, and pediatric neurology. So these are areas that we can begin to look into because we cannot take an area that people are not interested in and focus on that. So I think then for the division of training, that the division of training it's training also there must be a clear curriculum for training. So this has to be developed by the team that are involved in planning it. I think these are so for the comment that my prof and trainer is something we can look at and take it up from there.
Thank you very much for the comments and questions. They are well appreciated and noted for more input into the study. The definition for total penal loss is based on standards that have been developed as a grade 4 injury. The grading is based on the location of the external urethral meatus after the injury, based on how distal or proximal it is. So the more proximal is the one that is on the surface of the perineum, and that's the grade 5 injury. For some of them, there will still be some penal stone buried below the surface, which makes it possible to have this kind of salvage procedure. But for those who have no penal stone buried, then you have to look for other tissues to reconstruct. And when it is so bad and there's no skill for use of other tissues, that's why people go for gender reassignment. There's a popular story of a child that had an injury, had gender reassignment. He grew up to about 27 years of age and he committed suicide afterwards. You know, we know about genetic imprinting, so he was reassigned to be a female, but in his mind he's still a male, so there is conflict of gender identity. So that's about total penal loss. The erection, yes, at the initial stage is because of the length that is still short. The phallus tends to appear erect, but when the child is more relaxed, it tends to drop down. The reason why it's appearing erect is the fact that the length in suspensory ligament, which is advisable, because when you divide the suspensory ligament, it makes the phallus to appear gynecoid. So it's advisable to leave that ligament. When the child grows, this penile length increases, and then the phallus begins to drop. But the erection is confirmed by the fact that the mother and the caregiver are able to palpate and tell us that there is significant agony whenever the child has early morning tunescence. And the other concern we have is about future fertility, because based on the mechanism of injury, we are wondering that we have affected the ejaculatory duct at the perineum or not. This we cannot assess until much later in life. So the follow-up is a long time, and that's one of the things we are doing with the multidisciplinary team. So we keep following them on a monthly and yearly basis.
Thank you very much for the questions. I think we set preliminary report because this is an ongoing study that most likely will start to the end of October. We are hoping that by that time we'll have a significant number of patients to have a complete picture of what we are having. But we are aware that children support for children care, both at the level of NHIS or funds, are limited in our setting. And in a country where already most families are strained economically, challenging require surgery, push them more towards poverty and war. Thank you.
So thank you, sir. I think the error is from my side. The majority of the members of the union were bureaucratic, and many of the individuals were told.
So with this, I think we'll bring the session to a close. Dr. Kepa, do you want to have a word? He doesn't want to have a lot. He just wants to take photos. I think this has been a very stimulating session. Maybe ideas for research, ideas for symposium for the next conference. It will be very stimulating. Thank you very much. Thank you for the presence. Thank you very much.
The moderator of this session, the chairman, the co-chairman, and the director. Thank you so much. So we'll now move straight away to the next session. This session is one of the special sessions for our nurses and medical students in intern. So I would like to invite I don't know if she has arrived, the chairperson for this session, Dr. Lara Williams. Are you here? This will be a welcome tea break for you. Just come. So to co-chair this session will be one of our senior nurses, Dr. Abmalik. Is she here? Not here. So, and the rapporteur for this session, rapporteur is not here, Dr. Obi. Dr. Fawwe, are you here? Please, can you join Dr. Lara Williams on the IPM to moderate the session together? Thank you.
Good morning, everyone. Thank you for coming to this session. So we're going to call on the presenters for this session. It's the special session for nurses and students and interns. The first presenter, the first paper is okay. Some technical issues going on. The papers have been released, so the start those and uploaded. Yes. So, 2-week internship rotation in pediatric surgery, a narrative review of pediatric trauma management. Dr. Ahmed. Dr. Ahmed here. Knowledge and awareness of alternatives to advanced trauma life support in children among surgical residents in North Central Nigeria. Dr. Abdul Ghani. Is Dr. Abdul Ghani in the room? Okay. So the other paper is traumatic interparietal hernia of the spondylium variety in Tofa, masquerading as diaphragmatic hernia and unusual presentation. Dr. Olave, traumatic diaphragmatic fracture, pericardial and transdiaphragmatic herniation of abdominal viscera in the third lab on the portal case. Are we on that already? Okay, great. All right. And then Dr. Olave for parental perception. Not okay. And fine. You're here? Yes. All right. Okay. Oyeyemi Tio, so here for nurses challenge with the management of children with typhoid intestinal perforation. She's here? So can we come forward then? So that, all right, so Dr. Ahmed, let's have you first.
Good morning, everyone. I'm Dr. Ahmed Good morning. I'm Dr. Ahmed Alkar. I'm a lab. So you have 6 minutes, each person has 6 minutes for the presentation. When you have that, we will let you know and stop it. Allow me to sign on the existing protocol. As representing on behalf of the other co-authors, a narrative review of pediatric trauma management for a 2-week intensive rotation in pediatric surgery. Pediatric trauma has become the leading cause of morbidity and mortality with the incidence of 41.7 per 100,000 persons. The total of patients admitted within 2 weeks duration was 15, with 4 of them being involved in trauma. Mechanism of trauma included 200 bar injury from fall, while the other 2 were from penetrating abdominal injury. Pediatric trauma score stratifies severity of injury in children. So we have the severity scale of 0 to 5 being life-threatening, with 9 to 6 being potentially life-threatening. Then we have 9 to 12 being for minor trauma. So the objective is to give narrative review of a 2-week rotation in pediatric surgery units, to discuss the training cases involved in trauma in that 2-week duration with management and outcome. So the first case was IH 12-year-old male who was admitted with abdominal pain for 2 days. The mechanism of injury was for the handlebar of bicycle while riding. He had a pediatric trauma score of 6, and he had a diagnosis of generalized peritonitis secondary to blunt abdominal injury. The management included exploratory laparotomy with simple closure of ileal perforation. For the outcome, we had surgical site infection, which was managed with daily wound dressing and also antibiotics. He was discharged 27 days later. For the second case, we had OA, 11-year-old male who presented extensive total laceration exposing the testes, which was free of fall from while riding a bicycle with his leg caught between the handlebar. He had PTS of the line. Here is the image. So for the management, we had irrigation of the wound site and closure of the anesthesia, and he was discharged to the community. For the third case, we had WB, 6-year-old male who had penetrating abdominal injury with evisceration of the periton through a paraumbilical hernia. The mechanism of injury was for trapezoidal trying to climb the fence. He had a PTS of 6. The diagnosis was penetrating abdominal injury with evisceration of the periton. So for the fourth case, we had ISA, 13-year-old male who had penetrating abdominal injury from accidental discharge of firearm while playing with his cousin using their father's pistol, who was a social security service, the state security service rather. The mechanism of injury was aggressive penetrating injury, abdominal injury. He had a PTS of 4. He had monoparesis of the left lower. Here is a picture of the abdomen, the abdominal cavity. So he had for the management, he had a vaginal resection with also he had a vaginal resection following an exploration laboratory. So for the vaginal perforation, he had vaginal perforation with up to 6 vaginal perforation. And we had hemoperitoneum in the left paracolic gutter. We also had retroperitoneal hematoma on the left side, on the left vertebra, which should explain the monoparesis because checked the non-Boston expression was essentially normal, which had no bone involvement. So discussion. Trauma has steadily been on the rise in pediatric population. The causal relationship between all four cases was the gender, the age group, environment, and the outcome. Similarly, research demonstrated two types of patients involved in pediatric trauma being male. Also, what was wanting to be noted was the mechanism of injury. 70% of this patient had the mechanism of injury was fall, while the penetrating trauma contributed to 30%, which is consistent with the study done in 2020, which showed fall constituting 49% of the mechanism of injury of patients involved in trauma. Similarities in the four cases, we had the gender. Wanting to be noted was that all the patients were male. Also, they were all accidental, involving mostly at the same age group, with three of the patients being involved. Also, it was most of this trauma occurred postponed. In conclusion, trauma has become common in pediatric patients. About a quarter of the patients admitted within the 2 week duration were involved in trauma. Any adequate resuscitation and prompt management of injury remains the cornerstone in improving outcomes. Recommendations will include the need for awareness on increased incidence of pediatric trauma, the need for effective management for safe environments and against accidents, also early recognition and intervention prevents further decline and optimize the patient's outcome. Thank you for listening.
Take note of our questions so we can ask all questions and during the presentation. All right. Next, Dr. Abdul Ghani, knowledge and awareness of alternatives to advance trauma support in children among social residents and non-state
Distinguished ladies and gentlemen, please permit me to stand on the evidence and wisdom protocol. My name is Oliver Bidino. I'm a private medical student of the University of London. And today I'm presenting an research from IT, knowledge and awareness of advanced trauma and support modalities in kids and also residents in Western Canada. There is our outline. There is our outline. Trauma is a leading cause of mortality worldwide. In fact, it contributes 12% of the disease problem. And in the management of trauma patients, the advanced trauma line support was given to. So in the effective management of trauma patients, the advanced trauma line support was given them to, and the program designed to train physicians in the systematic management of
acute trauma and severe injuries. Despite this, pediatric trauma continues to be a significant complex challenge, and the reason for this is because the ATLS doesn't put into context different anatomical conditions you do peculiarities of pediatric care. Hence, recent studies have focused on new alternatives to ATLS. However, no study have been conducted on trauma resuscitation in Nigeria. Our aim is to assess the level of knowledge and awareness of ATLS alternatives to pediatric trauma among surgical residents in North Central Nigeria. And our specific objective is to assess knowledge of ATLS alternatives for pediatric patients among our target audience, and to also identify training gaps in pediatric trauma care to improve the curriculum residents in our target area, and also to determine the association between social demographics and awareness of pediatric trauma support and alternatives. A cross-sectional survey was conducted to assess the level of knowledge and awareness, and we collected our quantitative data using a structured questionnaire. And using the features formula, the sample size was established with 5 respondents. And then we used the convenience sampling strategy to select our respondents, and our data was analyzed using descriptive statistics. So our results, 74.30 of our respondents are senior residents, while 25.70 are junior residents. Based on years of social experience, 34.30% of our respondents have 6 to 10 years of social experience, while those with 1 to 5 years of social experience are about 31.40%, while those with 7 to 15 years of social experience are about 25.70%, and the minority are those with less than 1 year of social experience, which are about 3.60%. We also assess the knowledge of trauma resuscitation in Kenya. We noticed that 85.3% of our respondents have very poor knowledge about treat, while only 14.70% have good knowledge about treat. In satisfying our third objective, based on professional goal, we noticed that 8 out of the 9 junior residents respondents had very poor knowledge about treat, while 22 out of the 26 senior registrar respondents have very poor knowledge about treat. However, before this was statistically significant, and then based on years of social experience, we noticed that those with less than a year, all of them have very poor knowledge about treat, while those with 1 to 5 years of social experience, 9 out of the 11 that responded have very poor knowledge about treat, while those with 6 to 10 years of social experience, 10 out of the 12 that responded have very poor knowledge about treat, while those with 11 to 15 years of social experience, 8 out of 10 that responded have very poor knowledge about treat. And before this is statistically significant. So our study reveals a significant gap in awareness and training among our surgical residents. And even though 54.3% had previously received ATLS training, 85.3% are unaware of any alternative program, which indicates a limited exposure to diverse trauma management protocol. Even though most of them are undergoing ATLS training and done so over 6 years ago, which highlights the need for regular professional competence. And then finally, the social significant association between care and knowledge of residents or alternative to ATLS. In conclusion and recommendation, knowledge and awareness of alternative ATLS are also consequently, they need to integrate enhanced training programs and control trauma resuscitation and other trauma and alternative into the social curriculum. There are some of our references. Thank you very much.
Presenting from our city, interpretation of the Paediatric directive.
My name is Lalia. I'm fellow of the medical student of the University of ILORIN. And I'm here to present a case report on traumatic interparietal hernia of the spaghetti variety in Georgia, masquerading as a diaphragmatic hernia and an indural presentation. Traumatic abdominal wall hernias are experienced with an incidence of 1%. The typical results from these factors will not come. And is a little bit of it is located lateral to lateral versus academic muscle, and together blocks is a common feature of area. The aim of this is to report young variety. In 1991, years ago, experience on account of respiratory stress and more problem area. Consciousness, revision process, there was no material or application. There was no prior medical history of comorbidities. When examination discovered a child with stress, he was admitted to respiratory disorder, taking and attacked the report. It just all of asymmetry, with reference finding extending from the left hypochondral region, and creating line. The swelling was felt was regular and reproducible. The other one was blue and also motion. There was no area of computer tenderness. Examination needed. Normal area to an anterior. When I injury, query that was and it was adequately suspected. Imaging showed an absence in the left anterior wall. Features of his parents were outside and told the respiration appropriately following practice solution. It is found that the right in the anterior wall around the seminary facilitated by blue arrow, internal to that effect, tracking through the container left ground. Interparietal area direction of abdominal wall area, the established area, the majority of reported cases involve obstruction of the anterior abdominal wall, which may only include intra-abdominal pressure, which is directed to weak areas, such as the fascia, as seen in our case. Here area, which occurs at the intersection of the cerebral and abdominal, is typically challenging to the patient and also causes clinical stress. In this case, the significant blood swelling and show area along with the stress led to an initial suspicion of glaucoma. However, intergraph imaging and the presence of hormones in the detected otherwise. This case highlights the importance of careful identification and approach to distinguishing various types of injuries. The gold standard of diagnosis compared to over in case of processes such as the change X-ray or ultrasonography can be used in diagnosis. Any diagnosis and surgical intervention are very crucial to prevent complications such as power transfusion or perforation. In conclusion, particularly of the phenotype, great exercise in pediatric and this is understand the importance of thorough information and imaging. So that treatment and timely prevention and outcomes awareness of these conditions and potential implications can aid in any diagnosis and appropriate treatment and reference. Thank you very much.
morning, Chairman. Good morning, Co-Chair. Good morning, distinguished ladies and gentlemen. My name is Oluwa Okorbe, and I'm a faculty development consultant at the University of ILORIN. I'm presenting a case titled Right to Traumatic Pragmatic Culture with Pericardial Care and Transpragmatic Elation of Applicable Viscera in Ebola. Here are my outlines. The right the study of abdominal trauma such as traumatic appendage rupture and unnecessary occurring in only 4 to 6% of trauma cases compared to 8 to 9%. Instead of traumatic rupture is pretty on the left side and the lower effect of the back on the right side, and due to natural weakness of that on the left side due to openings such as the hiatus. The aim of this presentation is first to highlight the severity of infection, second, to increase awareness of diagnosis because sometimes symptoms will be delayed or subtle. So we are areas of suspicion and infection during the diagnosis. Thirdly, to share regular insights the human male for that emergency after being locked down. Sexual child just one child was mentioned. Emotion go to the top of the other, there are some energy on that side. The other was after the no palpable around there. There is the interest radiograph showing discontinuity of the diaphragmatic outline with poor pattern senses in the right radiograph. The was also mediastinal shift to the contralateral side, which is the left side. Following diagnosis of the right diaphragmatic rupture, the child underwent laparotomy and on a 12 centimeter the right diaphragm with a 5 centimeter pericardial was seen. There was also illusion of the transverse colon and also bolus of the small intestine. So the genetic contents were then reduced and the rights were repaired. Here is the chest photograph of the child on the second day post-op. It was mentioned that diaphragmatic rupture dates as far back as 1942 during a conference such as this, during the presentation of diaphragmatic hernia of children. Commonly associated injuries include liver injuries, infection of abdominal visceral organs, and very rare cases such as this, rupture of the pericardium. Mortality rate ranges from 1 to 20% and is dependent on 3 things. First, the timing of diagnosis, secondly, the presence of additional organ injuries, and thirdly, the severity of the injury. The most common diagnosis tool commonly used in the acute phase is a chest radiograph due to its availability and also effective affordability. But a computed tomography is the gold standard due to how sensitive and specific that it is. An exploration laboratory is recommended in such cases because it allows for thorough exploration of the abdomen to pick up injuries that were probably missed during imaging. Surgical repair of the cardiac should be performed urgently in order to prevent cardiac elation. Any reduction of the aneurysm content is also important to minimize the risk of strangulation or perforation of bones. In conclusion, this case highlights the severity of traumatic diaphragmatic rupture with pericardial tear in children and challenges faced during diagnosis. Early recognition and prompt surgical intervention is very important, and thorough intraoperative exploration is equally important to prevent life-threatening complications. Here are my references. Thank you very much for listening.
So the next presenter is
refer deeply parental perception and experience of care of the children in operating clinical difficulties to the University of Ilorin Teaching Hospital.
Good morning. Good morning, everyone. My name is Isabel Kutuko. I'm a nurse before the nurse that I'm a pediatric perioperative nurse from the University of Ilorin Teaching Hospital. Today, I'm the parental perception and experience of care of the children in the operating room of the University of Ilorin Teaching Hospital. Background of the study. Parents exert significant stress with the children when the children required surgery. Understanding parenting needs and experience allows for the development of a meaningful family-centered care strategy. This study aims to explore the surgical experience from the parent perspective and identify strengths that they can improve their experience. Method. This was a prospective study of the 20 parents and non-guardians of children who had surgical procedure in a Nigerian pediatric institution and in the Ilorin Teaching Hospital from July and August 2024. Majority of the respondents were parents, 20. The mean age of the respondent was 36.2 years. Majority were within the age of 25 to 45 years. The mean age of the patient was 5.7 years, slightly above us, and then were under 5 years. Most parents, 18, 12 were informed about children's surgery. Primary concern before surgery varied from pain management to the level and concern of anesthesia, which is none. Hello?
Okay, Mrs. Ricard, we should take the next presentation, but I would like to switch your slides. Right, we have a guarantee of, nurses trained to manage children with typhoid intestinal preparation. While we try to switch the slides.
Not our boss. What's what? Not our boss. But they want to continue technical end. Wait. We can't even used to end up maybe with you.
Good morning, Mr. Chairman, Co-Chair. Since priority to stand on the adopted existing protocol and arbitrary proposal, not the I'm going to present a study that says nurses challenges in the management of children with typhoid intestinal perforation. Typhoid intestinal perforation is a complication of typhoid fever, requiring prompt surgical intervention and meticulous nursing care. Quality nursing care. Nursing care is crucial for saving lives and optimal outcome. The aim of the study is to explore the challenges encountered by nurses, provide high-quality care to pediatric patients with typhoid intestinal perforation. The method was an online survey of 90 nurses working at the University of University Hospital. It was conducted using an online-based survey questionnaire. And here are the results. 80 responded were female, amounting to 88.8%, and 10 responded with 11%. Almost half, 47.7, had more than 15 years working experience, while the remaining respondents had less than 15 years. The average age of patients that were nursed were within 5 to 15, and 73 of the respondents managed that age range. That is to say, typhoid intestinal perforation is very, very common among the post-2 children. Forty-nine respondents, that is 54.4%, strongly agree that financial constraints hinders quality nursing care, indicating a poor health outcome and increased burden on healthcare system. While 2 respondents, that is 2.2, disagreed. 47, that is 52.2 respondents strongly agree that inadequate staffing leads to high patient to nurse ratio, affecting the quality of nursing care rendered. That is, when we have more than 10 to 20 patients to a nurse, that will hinder the quality of nursing care rendered, while 8 responded disagreed. The result also further states that 38, that is 42.2 respondents, strongly agree that when they don't present early, it increases the workload on nurses and will lead to increased morbidity and mortality rate. In fact, it's an issue in the unit when they come in very debilitated, very bad shape. Hence, it increases our workload and increases morbidity and mortality rate. This study also revealed that 29 respondents agree that lack of resources availability can be challenging, while 85, that is 94.4% of the nurses, find that inadequate nursing training can be a barrier in the care of these patients. In conclusion, managing pediatric patients with typhoid intestinal perforation and its challenges, the highlighted challenges, no staffing, no resources, no use of resources, as significant challenge on nursing care. Hence, recognizing and addressing these challenges will greatly improve nursing care as well as reducing morbidity and mortality rates. These are my recommendations. The government should provide good bottled water for the workplace. The government should provide adequate hospital equipment for use. The government and management should employ nurses for good nurse-patient ratio. We also advocate for health insurance policy to cover typhoid treatment as well as surgical treatment. Government should educate the populace with using mass media on good hygiene, eye hygiene, food hygiene, environmental hygiene to prevent contamination. Parents should be educated on every presentation to avoid further complication and lots more. Thank you for listening. Good morning once again. Once again, I'm not surviving the operative pediatric from Western University Hospital. The records ascension and experience of care of children in the operating room from the Western University. Background: parents exerting strength when their children require surgery. Understanding parental needs and experience allow for the development of meaningful family-centered care strategies. This study aims to explore the historical experience of the patient from the parent perspective and identify areas that can improve their experience. Method. This was the this comprehensive study of 20 parents and 1 guardian of children who has surgical procedure in the University of ILORIN Teaching Hospital between July and August 2024. Majority of the response majority of the respondents were parents, 20, mean age of the motions of 3%, almost all 19 parents felt very relieved. The primary concern for study shifted towards pain management, which is 14 respondents, and the recovery process, which is 13. Overall satisfaction with the entire surgical experience was high, with 12 of the parents being really satisfied and 9 satisfied. Conclusion. The surgical team were able to meet parents' expectations and exhibiting their concern throughout the surgical process. Pain management is the major concern during surgery. The parental perspective may help to the clinicians appreciate the parents' surgical experience and assist in improving family-centered care to children and the family. Thank you.
Presentation and compliment the LOC for this initiative, very interactive one and very businesses. Our conference this year and it's very brilliant to see the medical students. The floor is now open for your questions. So for the presenters, please make your questions and we want to know how to do it. Questions for the presenters?
Express my delight, as I'm sure I speak for everybody here, to witness shining next to strength and that God's mercy is coming. Impressive program like this. Please, if nothing else, I will ask that we make this a constant feature of all future programs. I'm sure we must manage other centers to do this. I'm very delighted about it. We always say that before you criticize, you must first praise people. to have praised you. But, let me say, however, this is to make things better. I want to see future of his life not be written in prose. His life should have no more than 5 words per line, and no more than 5 lines per slide. That's not subtracted from the beauty of his presentations today. So let his slides be simple and speak to his slides. And to one of the speakers, I saw 7 different colors on the title page. You should choose to put simple colors. Otherwise, this is great. I commend you. The innovation is also commend those who are speaking to speak up today. Thank you very much. Thank you very much. I also commend these medical students. I'm sorry I'm retired, I'm not teaching today. But please, the medical students, you can connect 50,000 for me. Good question. The main presenter is affirmative culture. In your first commentary, I did not say chest tube. The first part of it was the chest tube inserted or not? Then we want to recommend so many things for the government to do. She has forgotten that we just got a new aircraft and we will see. So I'm sorry that we don't know now.
Protocol. I'm very sorry to come in time of that some challenges that I have in my college. But I have to recommend this presenter this morning. And people were happy to reach my incentives this morning. It's a form of 22 challenges which belong my control. So for that, I promise we are going to make it less in the next program coming on pediatric nurses. For any technical problem, please just permit us to have it like that. We are going to improve the next session.
So to the medical students that teaching trauma. Basically, so this question goes to all of them. Trauma as it is a public health problem that is nutrition, considering the fact that we have such a high number of patients and kind of patients the way the narrative in the world. So I haven't presented something to trauma. So my question is, what, how should you address this as a public health problem to reduce reduce the incident and of course the impact of this? So we'll start with thank you very much. Child that have the right traumatic
the role of the lips and the soft palate in that process of feeding the child and breastfeeding the child. You need a complete formation of the lips and the palate to be able to attach and properly position the child for proper breastfeeding process. But this transformation, unfortunately, has altered that nature's position to be able to feed that child adequately. So the first problem we have with such children is to face the nutrition. Now, feeding difficulties, like I said, is a major challenge with them. And why is it a challenge? Once you cannot feed the child, the major intervention you need is a corrective surgery for this child. But once you have issues with feeding, it tends to affect your decision to be able to make a final, give a final treatment or management of the child, which is basically surgery. For the child that is not having adequate nutrition, what that will immediately translate to is the child will not be growing well, the child will be exposed to being malnourished. And of course, malnutrition comes with consequences. Lower immunity, displaces the child's health function, poor weight gain, and of course, this poses a threat to even people keep the child for surgery or even the child recovering from surgery. So nutrition is quite one important in this category of children. And studies have found worldwide that malnutrition has been a major obstacle to even offering surgeries, even when the surgeries are meant to be free, especially in the developing parts of the world. So malnutrition has prevented children from getting access to surgery. Something that has to be prevented, and proactive. Immediate consequences. To attack interventions that we can put in place to be able to optimize nutrition for those children pre-surgery and post-surgery. So you can go through traditional methods like I said, you express breast milk, use your cup and spoon to feed, while using breast milk fortifiers. You can also use specialized feeding bottles if they are available, if you have access to them, that you can they have special nipples on them. And you can also use modified nipples to be able to support feeding for these children. So these are some of the examples of specialized feeding bottles that we can use to support them, specialized gadgets that we can use to support them. In breastfeeding, as said, we can modify the technique of breastfeeding and even the technique of feeding. Basically, we want the child to sit in an almost upright position, slightly inclined, to be able to breastfeed or feed the child. This will allow you to prevent regurgitation or aspiration of feed, and you'll be able to deliver enough feed to the child as required. So, breastfeeding positions can also be modified with them, different positions. Instead of using the